Pleasure to invite Dr. Maha Hussain from Northern University to briefly summarize the data of the late-breaking abstract 12, olaparib for metastatic castration-resistant prostate cancer.
Thank you, Dr. Duran. It's my pleasure to be here in OLA. I am presenting also on behalf of all co-investigators the results of olaparib for metastatic castration-resistant prostate cancer. Here are my disclosures. And the study was supported by AstraZeneca. So the rationale for the study began with the fact that over the past 10 years, we have come to realize that metastatic resistant prostate cancer, what we call castration-resistant prostate cancer, is a disease that can have deleterious alterations in a variety of genes. Some of these genes are involved in the what we call HRR genes, that are genes that are that help the cell repair itself when there is damage. And so the intent here is to actually target those types of genes to prevent the cancer cell from repairing itself. And the genes here you're familiar with, primarily from breast and ovarian cancer, with BRCA1, BRCA2, and ATM. And so the clinical trial was designed with the intent of identifying men who have had metastatic castration-resistant prostate cancer, who have seen a hormonal agent frontline for this frontline treatment for this stage of disease, with drugs like abiraterone and prednisone or enzalutamide, which are available and approved in many countries. And then all these patients had to provide tissue, either from the original biopsies of their cancer from the prostate, for example, or from a new biopsy from the metastatic disease area. And then this tissue was tested with a Foundation Medicine special assay. And if the patients were identified to have the altered genes that would qualify them for study entry, they were then, and of course they had to qualify by other criteria, they were enrolled and stratified into two arms. One arm had the BRCA1, BRCA2, and ATM, and then the other arms had all the other potential genes involved. Both of the arms were actually randomized 2-to-1 to olaparib or doctor's choice of an oral hormonal agent, either enzalutamide or abiraterone. And then the primary outcome was actually progression by imaging, by scans, and the scans were evaluated by a blinded independent central review radiologist. The primary endpoint was actually looking at progression-free survival in the cohort A, and then cohort B was we were looking at several endpoints specifically there, including the radiographic progression-free survival in cohorts A and B, and then confirmed response rate, time to pain progression, overall survival, and several other criteria. The patient characteristics are outlined in here, and it's a little bit of a busy slide, but I just want to maybe bring your attention to a few things. Prostate cancer tends to be a disease of older men, so the median age of 68 or 69 is not an unusual thing for prostate cancer, but I think it's remarkable that men in their late 80s and even early 90s were eligible, were able to enter into this study and be treated on it, and I think that's an important point here. The other part is that in prostate cancer, there are cohorts of men, we call them de novo metastatic disease, meaning the first time you discover that they have prostate cancer, it's actually when it has spread. And this is a group of patients that tend to do generally not so well. And so this was about a fifth to a quarter of the patients. The other part it was to highlight is that, sorry, how do I go back? Oh. Okay. The other part to highlight is that this was a relatively heavily pretreated patient population. So while the requirement is that they had to progress on one line of frontline hormonal therapy for castration-resistant disease, many of these men have seen more than just the one-line treatment. Many of them, in fact, over 60% have seen chemotherapy, and in some cases, actually, somewhere about a fifth to a quarter have seen 2 lines of chemotherapy. So just to give you a feeling for the overall treatment history. These are the most common adverse events that were reported. And when we talk about adverse events, these are irrespective of whether the physician who is treating the patient considers them related to treatment or not. It's any symptom that occurs that is considered, a side effect, so to speak, but it may not necessarily be related to the treatment. Overall, the treatment was well tolerated, and the patients who were treated with olaparib had double the amount of the duration of treatment of 7.4 months compared to the control arm of 3.9 months. Olaparib overall had, relatively speaking, higher rates of adverse events. However, the majority of them were mild. They're not high-grade events. The only one that was relatively high-grade, that's a grade 3 or higher, was anemia. And I'm happy to answer questions about that. That was seen in about 21.5% of the patients. The overall adverse event profile is very consistent with what's known for the drug from prior clinical trials and other settings. This is the punchline, so to speak. This is the primary endpoint, which is radiographic progression-free survival by, again, independent radiology evaluation. And the median is 7.39 versus 3.5 months. Overall, I would say this is not only statistically significant, but clinically significant, with separations of the curves occurring very early in the process and continuing to even beyond a year in there. This translates into essentially a 66% reduction in the risk of disease progression, with a very significant p-value as highlighted in here of less than 0.0001. Now, there is a slew of secondary endpoints that we have looked at, including the overall cohort radiographic progression-free survival, which, as you see here, is, again, in favor of the olaparib, with, again, significant reduction in the risk of progression or death, as outlined in here, with a hazard ratio of 0.49 and a very significant p-value. Measurable disease, that is, for example, if you have a lymph node that you want to measure, or a liver metastases, and the rate of shrinkage of these lesions is what we call objective measurable disease response. So this is objective response rate in cohort A, which was 33% compared to 2.3%, with an odds ratio of response actually of 20.86, and again, significant p-value. And then one of the critical things in prostate cancer is pain, because prostate cancer goes to bone, and metastases that are poorly controlled in the bone can be quite painful. Time to pain progression was significantly delayed. It was not reached. The median has not been reached yet in the olaparib arm compared to the control arm, and again, significant hazard ratio reduction and significant p-value.
Dr. Hussain,
and then, yes,
we have to
almost done. Interim overall survival in cohort A, as you see, the separation of the curves have begun. The overall survival for both cohorts is not mature yet, so we anticipate outcomes next year, but this is very promising early signal. This is my conclusion, in that in metastatic castration-resistant prostate cancer, who has progressed on frontline hormonal agent with either enzalutamide or abiraterone, olaparib provided statistically significant and clinically meaningful improvement in radiographic progression-free survival in the primary cohort in patients with BRCA1/2 or ATM, and in the overall study population. Other endpoints of relevance have also been impacted, despite the fact that there was 80% crossover to the olaparib from the control arm. And I am delighted to say that PROfound is the first positive biomarker-selected phase 3 clinical study evaluating a molecularly targeted therapy in men with metastatic castration-resistant disease, highlighting the importance of genomic testing in this population, and also importantly highlighting the feasibility of precision medicine trials in this disease. Thank you.
Thank you very much, Dr. Hussain. So I will briefly comment about these very relevant abstracts. And I think the relevance of the work that Dr. Hussain has presented right now, I think is double. You have to understand that I think not only this work has proved that olaparib, this drug, is superior to the control arm. It's not only that. I think this study has demonstrated that now prostate cancer can be treated as a targeted or with a targeted therapy approach. Putting these in more simple words, not all prostate cancer patients have the same tumors. And this is the first time we've been able to identify that we can more precisely characterize the molecular biology, the genetic background of these tumors, and that is going to determine how we treat them. So double hit, superiority in terms of efficacy, and has proved a new concept that in prostate cancer had not been proved before. So targeted medicine works also for prostate cancer. Having said that, we're going to move to the next